I'm James Huston. Adam and I are both total joint surgeons here at LMH, and we have been happy in this last few months to be working with this Mako SmartRobotics robotic assisted surgery technology that LMH has gained in the last year. And so we wanted to go ahead and share some of the features and some of the things that it brings to the table, and reasons that we're excited to be able to use it and bring it to this community. So again, that covers a little bit of my background, being from Lawrence, and I'm grateful to be able to come back and serve this community.
And you can read a little bit about mine as well. Again, I grew up in Kansas and was very happy to get back here, and I think very pleased to work with Dr. Huston, and I think you'll see that having this technology really you can get anything that you could get at a big academic center right here in Lawrence, which is very nice.
So neither of us have any financial disclosures or affiliations to disclose for this, but we did get some of the slides and content from Stryker, and some of that's very helpful. So this just covers some of the topics we'll be going through, and the order. Start with some generalities about joint pain and arthritis, different treatment options before we ever even consider surgery, proceeding on to surgery, and all that entails, and then what to expect afterward, recovery, limitations, abilities, and what you can expect with a joint replacement. And then we can take some questions and answers at the end. Should come as no surprise that your joints are involved in pretty much every activity that we take part in, whether it's shoulder, hip, knee, ankle. Specifically, we're talking about hip and knee today, but pain and arthritis in those joints can significantly limit your activities and your ability to enjoy your activities every day. There's multiple different types of arthritis. The most common type of arthritis there in the middle is osteoarthritis, which is basically just wear and tear. Can run in families. Some people can be more prone to it just based on genetics and family predisposition. But it also just comes from use and can be developed over time, just as the padding or cartilage on the ends of the bones wear away. There are other kinds of arthritis, such as rheumatoid arthritis, lupus, psoriatic arthritis, that are all kind of categorized as inflammatory arthritis. And that is more of a systemic disease or issue where the body is actually contributing to the degeneration of the joint and eroding the normal padding and joint surfaces. Finally, post-traumatic arthritis, anytime someone breaks a bone into a joint or has an injury that involves a joint, it can lead to progressive arthritis or accelerated arthritis, and that can occur more earlier or more rapidly than run-of-the-mill wear and tear type osteoarthritis. There are many treatment options before ever discussing or needing surgery. Canes, crutches, walkers, these things can all help to decrease the load or the stress on your joints. Ice or heat can provide symptomatic relief and decrease inflammation. Exercise or formal physical therapy can help to strengthen the muscles, stretch, retrain kind of your gait and daily activities in order to be able to better support the joints from an active standpoint. And then there are medications, whether it be over-the-counter anti-inflammatories like ibuprofen or naproxen, prescription anti-inflammatories. We commonly do corticosteroid injections into joints to decrease inflammation. All of these things can help to decrease the inflammation, decrease the swelling and pain from arthritic, painful joints. And then certainly, very commonly, arthritis can be associated with being overweight or obese. And unfortunately, the hip and the knee take even an exaggerated brunt of that. 4 to 5 pounds, 4 to 5 times the body weight goes through the hip and the knee because of the bending and the mechanical stress involved with standing, walking, climbing stairs, walking on uneven ground. So weight loss can have a pretty profound effect of pain relief and improvement for many people. When you are dealing with this type of issue, there are a lot of questions to consider, but some very relevant ones include, is this affecting your ability to get to sleep or stay asleep at night? Is it affecting or keeping you from doing the things you want to, or is it keeping you from enjoying the things that you want to do or need to do? Is it causing you to stop doing things or be less active? Is it keeping you from being able to drive or walk up and down stairs or things of that nature? So kind of moving on to the specific topic here, the Mako robot and smart robotic technology is something that we're very excited to be able to use. And so we'll get into a little bit of how that works and what it is and how it can benefit our patients. This is not a brand new technology. It's one that's been developed over many years and has really evolved over the last 50 to 70 years from originally just using plain x-rays to plan these types of surgeries. In the 90s, computers began to be used to aid in the planning of this type of surgery. In the 2000s, some power tools with some sort of haptic or robotic navigation began to be developed. And then over the past 20 years or so, the Mako type robotic technology, where we can actually take a three-dimensional model, three-dimensional image of the patient's very own anatomy and convert that to a plan and institute that plan for a joint replacement surgery. So we'll start, we'll cover total hip, partial knee, and total knee. We'll start with total hip, which is going to be the most brief because it is the newest and at this point a little bit less commonly utilized. It's one that we are not yet using at LMH, but it is certainly something that we're keeping a close eye on and maybe something that we do in the future. So I'll kind of explain the utility in that. Looking at total hips, this is a list of the most common reasons for basically failure or reoperation after a total hip arthroplasty. About a third of the time, 36%, it's a mechanical failure, whether it be the femoral stem that goes down in the thigh bone, or the cup that goes in the socket, or the liners that go in between there. For one reason or another, if the hardware fails, that's about 36% of the time. Again, going right along with that, if those parts actually just wear out or have wear and tear between the parts, 21% of that is metallosis, which means that the metal is wearing and it's actually getting into the hip or knee joint and causing inflammatory issues. You can also have mechanical issues like the ball coming out of the socket, which we call dislocation. That's about 15%. Fractures, infection, other pains, these are all potential reasons. So as you can imagine here, many of these come from mechanical issues, whether it be alignment or something being slightly shifted one way or another. There are a lot of potential issues that can come from mechanical problems. So the desire to be able to put implants in just exactly how we plan and in exactly the alignment that we want is very important. So as it pertains to the hip, the Mako uses a 3D CT scan of the hip. It can project an acetabular shell or cup into the socket and see exactly how much bone is being removed in order to put that in, where it's going to be oriented, and then can use that to, along with markers on the bone that verify it, in order to help place it in exactly that orientation. And then it can be used intraoperatively to evaluate that and look for potential areas of impingement or issues that can go along with that. So the reaming or opening up of the bone is, again, it's haptically guided with the robot. And an image is visible for the surgeon to be able to see exactly how much more needs to be done and exactly where the tool is going within the bone. And then after that's done, the actual metal cup or shell that's going into the bone is again guided and allows it to be placed in exactly the orientation that was planned. So there have been many clinical studies evaluating this. And again, as we've said, the acetabular component placement accuracy, stability of these hips is improved. Short-term patient outcomes, meaning patients filling out a survey saying, how are you doing? How is your function? How is your pain? Are favorable. Forgotten joint score basically is a list of questions to evaluate whether the patient feels like they have a natural, normal, painless joint. And it's scored very well on that. And then something that's very important to us, especially these days when, to be honest, people don't want to be in the hospital for a long time. That's always something that we focus on, is having patients in the hospital as long as they need to be in order to be safe to walk and get around and go home with adequate pain control, but also not being there any longer than you need to, because it's not your home. It's not as comfortable a bed and familiar surrounding. So getting people home sooner is a valuable thing. Transitioning now to knees, there is as I said, there's a total knee and a partial knee application. And similar to the hip, the Mako total knee has been shown to have lower pain scores, quicker recovery times. The haptic guidance from the saw that the robot that we use with the robot is it's restricted, and so there's less injury to surrounding soft tissues, which leads to less pain and well-preserved soft tissues, and less cutting of normal healthy bone, because we know exactly what and where we're going to cut before we ever make any cuts. And so we'll start with, actually I'll just touch again that it's an exciting technology that continues, just like every technology, continues being developed and improved, but it also has a pretty well-established track record. It's about 15 years now of experience with surgery with this, almost 150 papers that continue to constantly be published more and more as we get farther out and continue evaluating. Over 850 hospital systems, over 1,000 patents, and 300,000 surgeries plus that have been performed with it. So the track record is certainly there. It's not an experimental treatment or anything like that, but it is constantly evolving and improving, and that's one of the things we're excited about. So switching to knees here. On the left, you see a cartoon of a normal knee that doesn't have arthritis. Glossy, white, smooth, articular cartilage is on the joint surfaces, the ends of the bones in the joint. And then on the right side, you see that cartilage is worn away. There is roughened surfaces, there's exposed bone, and that's very painful to walk around on and move. X-ray representation of the same thing. On the left, you see what a normal, healthy knee looks like with someone standing. That cartilage that doesn't show up on an X-ray makes it basically look like that femur is floating. It's got a nice symmetric space between the femur and the tibia. And then on the right side there, it looks like that bone is sitting right on bone. And that's a painful way to stand and walk and move around. So ways of treating that, on the left, again, you see a partial knee replacement. So this is what we call the medial side of the bone. If you have isolated arthritis on this side, but the rest of the joint is in good shape, a partial knee replacement can sometimes be a good option. Whereas for a lot of people on the right, you'd see that the entire knee has arthritis in multiple areas, whether it be behind the kneecap, the outside, the inside. And in that situation, we do a total knee replacement where all of the joint surfaces of the knee are being resurfaced with metal and plastic, and all of those painful areas are corrected. Specifically talking about partial knee replacements, this would be an X-ray that would be a patient who potentially would be a good candidate for a partial knee replacement. On the medial side here, it's bone on bone. And on the lateral side, if you kind of covered up the other half, it looks like a pretty normal knee. So isolated medial arthritis, well-preserved lateral and patellofemoral, which is the kneecap compartments. And then it's not just about the X-ray. If the patient has a lot of pain laterally, we have a low level of interest in doing a partial replacement for someone who has pain on the other side of the knee, because I don't want to continue to have someone have pain in a knee that's been replaced. So the patient's symptoms have to match with the X-rays for sure. And then we always get what we call valgus stress, where we basically try to close down this side of the knee by pushing on it. So we get an X-ray pushing on that knee, and if that space still stays wide open, it indicates to us that there's good, healthy, thick cartilage padding on the lateral side of that knee, and it's a good candidate for a partial replacement. So by far the most common type of partial replacement is medial, meaning this inner aspect of the knee is the most common area that develops arthritis first. And so that is typically the type of partial replacement that is done. There are lateral and patellofemoral isolated replacements. They're not done as commonly, and so at this time we don't do those. We generally do a total knee instead, but just for interest of completeness, they're included there. This has not been, I think it may be an issue with the LMH Wi-Fi, so I'm gonna let Dr. Goodyear maybe play this video if you have that keyed up.
Yeah, can you stop?
Yes, I'll stop sharing there. So this is basically, it's just a video or a cartoon showing how the basic steps of the workflow go, and then showing in generalities how that works, and then we'll get into a little bit more specifically.
A second, guys. Share screen. There, can we see that?
Yes. So starts out with a CT scan. The patient's, it's not a CT scan of the entire leg, but it does capture images at the hip, and then fine 1 millimeter cuts through the knee, and then cuts at the ankle in order to get the whole leg alignment. And then it creates this, or we create this three-dimensional model of the knee and superimpose the actual knee replacement parts in the preoperative plan to see exactly how it fits to the bone. And then by the time we get into the OR, we already have a general idea of how that's going to fit and where it's going to go, what sizes are going to be, and how that's going to look on the bone. And then once we get into the OR, we have to register and confirm that the patient's actual anatomy during surgery matches to that three-dimensional template that we have from the CT scan. Once we've done that, we take the whole leg through a range of motion, rotating the hip, moving the knee, and balancing out the knee so that it moves just the way we want it to before we ever make any cuts. Once we've done that, then we actually remove the arthritic bone in order to resurface the joint. And there's a screen actually in the OR that you see on the left there that shows what has been resected and what still needs to be trimmed in order to make room for the implant. So I think it's about done with that. If you want to stop sharing, I'll take it back. Okay. So again, just to cover the steps there that we kind of breezed through in the video, each patient gets a CT scan, and that CT scan is converted to a three-dimensional plan for the surgery. The implant is overlaid onto a three-dimensional model of the bone. We assess the range of motion, the ligament balance, all of these things in person during surgery, and make adjustments before we've ever made any cuts. We're able to see how those adjustments will impact the balance of the knee, the motion of the knee, again, before actually making cuts. So all of this is worked out before doing any of this with a saw. And then once that's kind of locked in, we're able to make those cuts to prepare the bone for the replacement with really good confidence that it's going to balance out just the way we want. So as this pertains to partial knees, partial knee replacements are, it's a great surgery, but it's a smaller surgery, so it has to be very precise. If the alignment or the balance is not done well, then they can definitely fail. And so that's part of the value of this technology for this surgery. As far as the partial replacement, as you can see here on these images from the CT scan, it's only replacing this one area of the knee. And so you can see exactly where that's going to go before you resurface it. And then we can actually use a probe, touch it on the patient's normal surrounding cartilage, and get a three-dimensional kind of depth analysis of where that implant is going to end and where the normal cartilage starts, so that it's a totally smooth transition from metal to nice, smooth, normal cartilage up in this area. And then we assess the balance with the knee out straight, with the knee bent all the way, and then at multiple locations in between, and make sure that it's really balanced at every spot along the arc of motion. So then that three-dimensional plan is created. For the partial, we use a burr to create the space on the femur, and then a saw for the tibia. And that implant is prepared and placed. You can see we are registering it to the patient's anatomy, balancing it, making sure it's going to fit just perfectly, and then preparing the bone for it. So again, as far as partial knee goes, the evidence shows 55% less pain in the first 2 months after surgery. 97% survivorship, meaning when we say survivorship here, it means that the actual implant itself is still in the patient, hasn't required any further surgery, and is still functioning at 5 to 6 years. So only 3% failure rate, basically. Oops. And then in the Australian National Registry, where every surgery, every replacement gets entered, only 1% basically rate of having an issue requiring removal or redoing in the first year. So that tells us that it's doing very, very well. Again, this is a partial replacement on the left and the total replacement there on the right. This is what it looks like in person here, a photo. This is a partial replacement, and this is a total replacement. So we'll transition now to total replacements. I'll let Dr. Goodyear take over the screen, and I'll stop talking.
Sorry, Dr. Huston gave a nice summary of the hip and the partial knee. I'm going to keep talking about the total knee. So this is kind of how a total knee replacement works. Dr. Huston kind of already showed this cartoon. Basically, you can see there the metal on the end of the femur, which is the thigh bone, metal on the metal cap on the end of the tibia, which is the shin bone, and then the piece of plastic in between. You don't see the kneecap here, but you keep your own kneecap with a button, a plastic button underneath the kneecap. So this is what our Mako robot looks like, and it's got little attachments that go onto that arm right there. Well, the main one that we use is either a saw or a burr in a partial or total knee replacement, and for a total hip replacement, we use a reamer, typically speaking. So challenges in total knee arthroplasty. One of the biggest challenges that we run into is that 80% of people that get total knees are very happy with them, but that leaves 20% of patients that are not totally happy with them. In America, when we're doing, by 2030, I think we're going to be doing 1 million total knees a year in the United States. That's a lot of knees that people aren't happy with. So one of the key drivers in robotics is trying to figure out how to make that 20% smaller. There's a lot of different reasons that total knees people don't like them, or that they need to be revised for various reasons. On this slide, you can see infection is a big reason why. Malalignment can become a big reason why. And joint imbalance can become a big reason why. From a previous study, the overall rate of revision could potentially be reduced by 25% if we balance the ligaments more accurately to what each specific patient's anatomy would dictate. And one of the nice things with the Mako robot is that we are able to specifically balance the knee based on each person's specific anatomy. I'm going to stop sharing my PowerPoint slide, and I'm going to show another video demonstration here. Just give me one sec. And this will give us kind of an idea on what exactly our workflow is intraoperatively, which I think can be pretty neat for people to see. I will say that this does have some surgical video in it, so please be aware of that. And again, I'm trying to find the right thing to share here. Okay, here we go. So at the beginning of the case, we have this 3D model that you can see. So this is based on the CT scan that we've obtained preoperatively. We can move this around and rotate and see all of the different osteophytes that each patient has. You can see you can rotate that before surgery and look at it. And then you place these trial implants, and we know exactly, based on the plan that we've come up with, what size we're going to go with prior to making any sort of cuts or anything like that. Then we go to our bone registration. So this is once we get everything open and we're looking at the bone, you can kind of see over there on the right video of what we are doing. And then on the left, you can see what we're looking at and registering the CT or the program, making sure that the anatomy matches up with the CT scan. So that's one of the things. And then after we register the bone, we get to the point where we are balancing the ligaments. And before we make any cuts, like I said, we can test each one of the ligaments that we're focused on, and we can balance those down to the millimeter. You can see the millimeters that we are looking at here. And from a technical standpoint, we try to make sure that the flexion and extension numbers are equal. We can make adjustments. And so what we can do is move the implants up, back and forth and rotate them so that we can adjust and make those numbers equal down here on the lower right hand side. Then what we do is once we have our plan complete and the ligaments balanced, we do our bony cuts. And the robot, what it does is, you can see over here on the right hand side, the video, our hand is always on the saw. We're dictating the cuts, but the haptics, which is basically the program that tells the saw and the robot where the knee is in space, will not allow us to deviate outside of the parameters that we already put in to make those cuts. Now we can adjust this on the fly if we need to, but most of the time, once we make a plan, we make those cuts and that's it. But you can see we actually look at this screen on the left when we're making these cuts. Okay, and then it's the same concept on the tibia, meaning the shin bone, top of the tibia. We just shave off the top portion of it, and again, we go based on our preoperative or our plan that we created, and then the robot dictates the cut for us. One nice feature that I like to show is that, and Jamie alluded to, the fact that we cannot deviate outside of these parameters. And you see this person that's trying to demonstrate this, he's trying to push really hard against these boundaries, and he can't go. The robot will not allow him or her to go past that point. And once we've made all of our cuts, what we do is our trial. And so we have trial components in there, and we're able to take real-time measurements of what we ended up with, which most of the time it's exactly what we planned. And we can see how balanced our ligaments are. And again, we want them as equal as possible in the flexion and extension. And again, one nice thing about the robot is that each person's anatomy is taken into consideration specifically. When we do these total knees, when we do them manually, we're going based on, excuse me, sorry guys, trying to multitask here. Can you guys see that? No, this is the wrong one, sorry.
It's back on your PowerPoint.
Oh, it is? Okay, good. Perfect. Trying to, can't seem to figure it out. Sorry, guys. It's not clicking through. Give me one sec. Not sure what happened. Is that better? Okay, there we go. Okay, so what I was saying was, with a manual knee, we go based on anatomic averages throughout the population, but because of the robot, we can go based on each person's specific mechanical axis, which helps us to put the knee in more precisely for each patient. And that's just kind of detailed based on the CT planning. We kind of discussed the dynamic joint balancing, where we are able to, again, intraoperatively determine exactly the appropriate balance for each individual person, which is very nice. And then that haptic technology, where the saw is not allowed to deviate from any of these boundaries that we create prior to making any cuts. And again, this is the workflow that you could see in the video. So, and then this is just a patient of mine that had, you can see arthritis on the left knee over there, and, or excuse me, the right knee, and this was her post-operative x-rays. So then once we get done, well, what is the success rate of the robotic knee replacements? And this has been, the Mako has been around for years. They started with partial knee replacements, and then the total knee replacements were next. So and this has been around for several years, and it's been studied actually fairly extensively at this point. And what they've shown is that there's less bone and soft tissue damage, less need for pain medicine after surgery, less time for people in the hospital, less need for inpatient physical therapy sessions, and less post-operative knee pain. There's studies that come out every single year that are adding to the benefits of this. So then we just wanted to talk briefly about the recovery after a joint replacement, and that is one of the nice features of the robotic knee replacements, is they tend to recover quicker. So people after surgery, you will you'll have your surgery. Depending on what you and your surgeon decide, you'll either do an outpatient total knee, or you will stay in the hospital overnight. After that, we start physical therapy from the very beginning. We follow up several times in the post-operative period, and continue to follow patients on a yearly basis. In hospital recovery, depending on where we're starting to do outpatient total joints as well. So you may or may not be in the hospital. We